Okay, I think we're recording. So good afternoon and welcome everybody to this, the last in the series of the member webinars that we've been holding in 2022-23. We have got some more webinars coming up in the new financial year, but this is the last one for this year. And I'm really pleased that we've been able to secure Lindsay Burgess, who's from the NHFT Diabetes team, to talk to us about diabetes this afternoon. Before I hand over to Lindsay, just to explain a little bit about how these sessions work. So it's designed such that there is a little bit of information shared from, in this case, Lindsay about diabetes and the team, the service that we offer in NHFT. And once Lindsay's been able to talk through her materials, we'll then open out for questions from the audience, so to speak. So feel free as we're going through to put a question in the chat. At the end, we'll invite people to talk. So we will use the raise a hand function at that stage. So I think with that, unless anybody's got any points they wanted to raise just at this moment, I will hand over to you, Lindsay, to start taking us through the slides. Thank you.
Hello everyone, can you hear me?
We can.
Oh, brilliant. I'm not in my normal location today. We've had some carpet fitted indoors and there was an awful lot of banging going on, so I'm actually in the cabin at the bottom of my garden where my son lives, so hopefully he won't interrupt us on his way home from work.
Excellent.
So I've had to cobble together my two screens and everything, so I've been frantically playing. It's lovely to be with you. As Richard said, I'm Lindsay Burgess. I'm Diabetes Pathway Lead with NHFT. I've worked in diabetes care for more years than I care to remember. Started originally as a diabetes specialist nurse and was then a manager for the diabetes specialist nurses, and now I guess do a lot of management. It feels like a lot of management for diabetes and high risk for diabetes retinal screening, the MDT, and we have a small team of paediatric diabetes nurses that we support at KGH. So introduction, I'm going to focus on the MDT, but I will also show how we interact with other services across the diabetes pathway, and we're not in the middle even, we're just kind of starting a transformation of the diabetes pathway in Northamptonshire that affects NHFT, the ICB, primary care across the whole pathway, and we haven't looked at that for probably around 12 years. So likely to be a major job and not finished very quickly. So I'm focusing on the MDT. But we'll look at other interactions. And I like to think about diabetes as being a bit of a journey that people go on from diagnosis and through a life lived with diabetes. Any idea how long we associate insulin with diabetes, of course. Any idea how long we've had insulin available to us in the world?
101 years.
101 years, absolutely. And it's interesting trying to think about how the world would have been 101 years ago without insulin. We certainly at that point didn't have any treatments for type 2 diabetes either. I've just come from the patient engagement group as well, and we had a patient story, and he'd written a lovely, almost it felt kind of like a short story really, about 50 years as having type 1 diabetes. And he's got the 50-year medal from Diabetes UK for living with diabetes for 50 years. And he was writing about the changes that he's seen in his lifetime, the chemistry set of testing urine, the test tube and the tablet. And people that have been around for a long time will remember that I can't remember what it was, 10 drops of water and 2 drops of urine in a test tube and a tablet, and it fizzed up, and it might go any shade between blue and up to yellow, and that would denote how much sugar was in his urine, which would then reflect on how much sugar was in his blood. Glass syringes he had to boil and store in methylated spirits, needles that he had to reuse and resharpen, and how just the incredible changes that have happened over his lifetime. And tragically, he was saying that there was no retinal screening. There was no thought of checking his eyes for any damage. He was diagnosed when he was 9. And when he finished college, he developed eye problems and is now partially sighted. So, very different world 50 years ago as well. And the change seems to be cracking on a tremendous pace at the moment. There seems to be a lot of change in the last 10 years, I would say. Next slide, please. So I thought today, let me see. I'm trying to operate my slides as well so I can read my notes. So I thought as an agenda today, we'd have a look at what diabetes is just very briefly. And think about the diabetes pathway in Northants as it is at the moment. Think about reasons for referral to the community diabetes team, the diabetes MDT, thinking about staff training projects, collaborating across services, and how people would contact the diabetes MDT, and then we can have some questions and answers. Next slide, please. So what is diabetes? Any thoughts? What do people think if we stand in front of a group of people with diabetes and say to them, what is diabetes? What kind of things do you think they might come up with? Just shout out, anyone.
Well, I suppose you could start by saying that the pancreas is, well, it depends if you're defining type 1 or type 2, but it's the inability of the pancreas to produce or overproducing insulin. So the inability of the body to manage, effectively manage blood glucose levels in the
blood. Yeah. Any other thoughts?
So I think
I would go
Chris
I
next.
would say, sorry, I didn't mean to go. It's a medical lifelong condition, and Judith's right in terms of the clinical diagnosis, but for a lot of people it's also awareness. And I think for some of our communities, or less represented communities of it, if I may, like for example the Southeast Asian community, it's also knowing what the signs are and when to seek help, actually. So I would describe it as a chronic lifelong condition that needs managing. And in the public eye, most people think of type 2 because it's weight. But looking forward to what you've got to say, actually, Lindsay. It'll be very instructive. Thank you.
So yeah, so most people would come and say it's something to do with sugar, something to do with the pancreas. Maybe so they might come up with insulin sometimes as well, something to do with a deficiency of insulin in some ways. But yeah, you're absolutely right. It's a chronic lifelong condition. It affects people differently, and certainly when insulin was invented or created in 1922, it was heralded as a cure for diabetes. And it wasn't many years after that people then realised there were other concerns relating to diabetes, other long-term effects of diabetes that we really needed to be concerned about and worried about. So we think it affects between 5 and 10% of the population. You're absolutely right. The higher percentage would tend to be seen in the Black and South Asian population. The split that you've got your two types of diabetes, your type 1, your type 2, and the split between the two types of diabetes, probably 10% type 1 and 90% type 2. We try and focus on no blame, particularly in type 2, and thoughts of we can probably prevent, we could probably delay rather than prevent. We don't absolutely know enough yet. The studies haven't been long enough. But type 2 we associate with lifestyle, and that's the one you tend to hear a lot about in the press. But lifestyle is only one part of that equation. You've still got your genetic makeup. It runs very strongly in families. We've got an aging population, of course, and as we get older, we tend to develop a lot more conditions, and certainly age is a risk factor for developing type 2 diabetes. And some people can develop it as a result of steroid treatment, antipsychotic treatment, or maybe injury, accident, surgery to the pancreas. So there's other things rather than just lifestyle to focus on. Type 1 is an autoimmune disease, so we know even less about type 1 diabetes. Something triggers it, maybe something viral, maybe something environmental. We have years where we have quite a lot of people diagnosed with type 1 and years where we don't have very many people at all diagnosed with type 1. We haven't quite pinpointed the reason for it yet. Peak onset, of course, for type 1 is childhood, adolescence, young adults, probably primarily adolescents. Worst possible time for someone to develop type 1 diabetes, of course, just as they're becoming very self-aware. And genetics do play a part in type 1 diabetes. There's been studies going on since forever, looking at whether we can detect people who might be at risk of diabetes, who might develop type 1 diabetes. And then, of course, you've got to think about what we can do about that. So lots of research, lots of studies, but we do try and focus on, trying to get rid of that blame, that it's all about lifestyle that people tend to hear an awful lot about. Of course, our lifestyle today is an effect of evolution, isn't it? 100 years ago, we would have been, pummeling our washing by hand, wouldn't we, with a stick in a drum and washing up and mining for coal and farming in the field. So our life is very, very different now to what it was 100 years ago. And some of those things are just are out of our control, aren't they? Next slide. So thinking about the diabetes pathway in Northants, I quite like this picture I've put on this slide, really. We deliver patient education, and one of the sessions we talk an awful lot about target blood glucose, and we think about that target for the average blood glucose reading, the blood test that people have once or twice a year. And we talk a lot about, okay, there is that target, but actually getting close to that target, being around that target. If you've got a lifelong condition, you're never going to hit that target all the time. And sometimes there can be that feeling guilty that you're not hitting the target. They can also be that sort of waggy finger effect of not hitting that target for your blood glucose control. But quite like this slide, because actually you will probably vary around that target for most of your life. You'll have good times and you'll have times when it's not so good, but getting around that target, we know, is really good for people's long-term health with diabetes. So I thought about the pathway in Northants and looking at where people will be seen for their diabetes. And if we start with primary care tends to be the first port of call. So they'll often get involved in the diagnostics around diabetes. Certainly the annual reviews, the yearly checkups people should have for their diabetes. The 6-month reviews, that little bit in between their annual review to see how they're getting on and just make sure that things are running along smoothly. And involved in titration of medications according to NICE and local guidance. And of course, often put the port of call for troubleshooting as well. So thinking about that annual review people have for their diabetes, any thoughts about what people should be checked on a yearly basis? Heard of any of the checks that people with diabetes would need on a yearly or annual basis?
I do.
Yes, Chris?
No, somebody was before me.
I said I do, but I'm going to cheat because I'm a type 1 diabetic.
Oh, go for it.
So eyes, heart, blood, HbA1c, feet. Yeah. I won't say all of them. I'll let somebody else have a pop.
Yeah.
Eyes as well.
Yeah, yeah. I was just about to say I'm no expert or clinician, but in a previous life I've managed diabetic retinopathy screening service. So I would, like Judith just said, I thought some form of ophthalmic review would be required.
Yes, yes. We often call these the 8 or 9 care processes that people should be checked for on a yearly basis. That yearly check is also the opportunity for a review of where people are, looking at a care plan, maybe a plan of action for the following year in relation to their diabetes, an opportunity to review their medications, those sorts of things. But yeah, checking of feet, the annual eye screening, checking of blood pressure, cholesterol, kidney function, looking at urine tests for kidney function. So yeah, you know, a really good checkup, a thorough review of where they are with their diabetes. And that 6 month in between one is usually looks at their diabetes, their what we call the HbA1c, or the average blood glucose result, that gives you an over 3 month period and average check of the blood glucose. It can give you that idea of whether people are running along nicely or whether things are fluctuating. Weight. I don't think we said weight as well, so we would check weight as well. Weight is a very good measure. We don't like to see it as a threatening thing, but it's a very good measure of the stability of someone's diabetes. If blood glucose is running very, very high, then people will tend to be losing weight. If it's very, very low, people can often be gaining weight because they're having to eat extra to keep their blood glucose up. So weight is a really valuable measure as well. So yeah, primary care or your GP services are responsible for that kind of routine checks, I guess you would say. Secondary care or your hospital services often refer to seeing people with about the Super 6 or the Super 7 conditions in relation to diabetes. So emergency care, so when people need to be in hospital, maybe the two extremes of diabetes management, when blood glucose is really, really high and people are becoming unwell because it's really high. People with type 1 can get something called diabetic ketoacidosis, but equally people with type 2 can become very unwell as well if their blood glucose becomes dangerously high. So that emergency care, very low, where people are maybe having hypos and collapsing. Your hospital care will be involved in those scenarios. Insulin pumps, so people with type 1 diabetes can be treated with or managed with insulin pumps now, and that technology is managed in a hospital setting by a specialist team. Insulin pumps, not for everybody, but increasing in numbers. Again, I can remember when people self-funded their insulin pump. And I can remember the first 4 people in Northants who had their insulin pumps, and they were all self-funded. And then we moved into criteria for people to qualify for an insulin pump, and followed the national guidance from NICE. Can't remember how many people we've got on pumps now in Northants, but hundreds. Lots of children tend to qualify for an insulin pump very easily if they want one. Adults, there's still criteria that we have to work through and meet. So an insulin pump will administer insulin almost like drip by drip by drip, if you like, constantly. So people will wear the pump, they'll have a cannula in their skin, and the insulin will be delivered constantly, drip by drip by drip. And it's usually the quick acting insulins that are used in the pump, or not usually, it's always the quick acting insulins that are used in the pump. And the advantage of an insulin pump over normally injected insulin is that you could design your own regime, really. You can design that drip rate, if you like, to suit you personally. You're not having to manipulate your lifestyle to fit around the action of an insulin. You're actually designing that drip rate so that it meets your highs and your lows and keeps your blood glucose subsequently more stable. And obviously you're not injecting 4 or 5 times a day. You're literally just changing a cannula, usually every 3 days. And then at meal times you have to give what we call a bolus of insulin. and we normally work that out against carbohydrate values. So people will become very adept at working out how much carbohydrate is in their food, and therefore how much insulin they need to inject for their food. And the pumps also give you that opportunity to turn up or turn down that insulin delivery. For example, if someone's unwell, they might need more insulin. If they're exercising, they might need less insulin, and so on and so forth. So they're very flexible, but quite demanding. They're not an easy option. I think people often think you know, put someone on an insulin pump, that's it. They don't have to think about it anymore. It's not that at all. It really is quite labour intensive. You have to be really switched on. Because there's only quick acting insulin in a pump. If the pump fails, then blood glucose can become high very, very, very quickly. So potentially very dangerous if people are not, you know, monitoring themselves, you know, at least sort of 4 to 6 hourly to detect if their blood glucose is changing. Lots of newer technology as well is beginning to link up the pumps with that continuous monitoring as well. So people talk about a cure for type 1 diabetes, and I think you would think that the technology will get there first. We'll have brilliant technology that will act like a true artificial pancreas before we get to a cure for type 1. That's generally the thinking at the moment. So the continuous blood glucose monitoring means that people can see the trends of their blood glucose. They can see where it's beginning to rise. They can see where it's beginning to drop. They can study patterns over days and weeks and use that information to manipulate their ratios, their background rates of insulin and everything. But with the linked pumps, where the pump will link with the monitoring, we're beginning to see that opportunity for the pump to respond to the blood glucose readings it is getting from the continuous monitoring. So if the pump can respond and just turn up the insulin or turn down the insulin, you can prevent things becoming dangerously high, and you can prevent things from becoming dangerously low. And you can achieve what we tend to term more now is blood glucose in target. So we're seeing people having their blood glucose in target for much longer periods of time than you can possibly achieve just by injecting insulin. So technology is really moving on quite a pace. Pumps have an inclusion criteria. You have to meet a criteria for the pumps. The continuous blood glucose monitoring, again, you need to fit criteria to qualify for that technology as well. And it's always a bit sad as well that actually the people that often work the hardest to manage their diabetes exclude themselves from that exclusion, from that criteria, just because by default they're managing the challenges that they are facing. But that's not to say there aren't some people that do everything in the world to try and get it right, and they still can't quite get there. And of course the technology may be the only way to go to actually help them keep their blood glucose within target, because ultimately we're trying to keep people well for longer. Antenatal care. Again, in hospital services, people who develop diabetes in pregnancy, gestational diabetes, and women who have diabetes and then become pregnant will be managed in the hospital services as well. When you're growing a new human being, those blood glucose readings need to be absolutely perfect, probably even more perfect than we would aim for normally, because quite naturally in pregnancy women's blood glucose is on the lower side, so you're trying to achieve that in gestational diabetes as well. So it's blooming hard work keeping your blood glucose to target for usually more than the 9 months, of course, because people are then preparing for pregnancy, so they have to achieve that before they conceive. Or ideally, we recommend they could achieve that before they conceive, and then maintain that for the 9 months of pregnancy. So it very, very hard work for people with diabetes to grow a new human being, but really, really important for the health of mum and the development of the baby. Again, in hospital care, children managed in that specialist setting by specialist teams. And then during adolescence, we have transition services where children somewhere between sort of 14, 16, 18 will start to transition from paediatric service into the adult services. And then certainly with type 1 diabetes, we would ideally keep people in that sort of hospital-based service up until they're 25. It does rely on people engaging with services. So if people stop engaging, then they'll get discharged from those services. But often after they get to 25, they, you know, and if people are doing really well, they may well then be managed in GP services. National guidance would suggest that people with type 1 are managed in secondary care services, in hospital services by specialists lifelong. As with everything in healthcare, there just isn't the capacity to do that for everyone, and not everyone wants to be managed in that style of service either. So some people are very self-contained and do, you know, very, you know, brilliant job, and really all they need is to be able to have those annual screenings done to make sure everything's ticking along nicely, and dip into specialist services maybe when they really do need that help. But nationally, ideally, you would have people with type 1 accessing specialist services. If people aren't, they often miss some of those new technologies and new treatments and things because they're often started in specialist services. So if people with type 1, you know, quite shockingly, you do find still that people, you know, we meet someone who hasn't been accessing specialist services and they're completely unaware of the continuous blood glucose monitoring and things like that. It's just passed them by and they've not heard about it. So ideally, people with type 1 would be in specialist services, but not exclusively. And even if people are in those secondary care services, those annual reviews in primary care are still really, really important, because the GP has the I don't know what you got, the setup, if you like, to actually monitor and recall and check to make sure all those annual checks are being done. They're, you know, GP services are much better set up to do that. So anyone with complex medical issues, so diabetes with renal problems, or diabetes and unstable cardiovascular disease, or diabetes and some of the long-term complications of diabetes, like gastroparesis, where the gut doesn't empty properly. There can be delayed or erratic emptying of the gut, and therefore absorption of food, particularly of course sugars from the food, which then make blood glucose very unstable. So complex medical problems often associated with type 1 in secondary care, but yeah, there will be people that are very complex that will need to be with type 2, who will need to be seen in hospital services. And often, as we know, new therapies, new treatments, new therapies, new technologies often start in the hospital service before they're eventually released out into the community and into GP practices as well. And then we come to community services, and the community services run by NHFT. So NHFT look after the retinal screening service. So this fits in with the National Retinal Screening Programme. So they hold the North Hants register, if you like, of everybody with diabetes in Northamptonshire. And late last year, it went through 50,000 people. So there's 50,000 people on that retinal screening register. And I think that's children from 12 and above go onto that register. When we formed the 12 years ago, so when we originally did the pathway for diabetes and the diabetes MDT was formed, we were basing that on a population of 28,000. So in those sort of 10, 12 years, we've gone from 28,000 to over 50,000. So it's a huge increase in population. I'm pretty certain we've not had the same increase in staffing. And it's true across the health pathway, isn't it? That we've got an aging population, we've got more people in the country, full stop. NHFT also provide the diabetes and high risk foot service, sometimes referred to as podiatry. their focus is really on that really risky diabetic foot. So long-term complications of diabetes, people can lose feeling in their feet primarily. And if you're losing feeling in your feet, you are at risk of injuring your feet. Cardiovascular disease is more prevalent in people with diabetes. So if you've got poor circulation down to your feet as well, that risk of injury compounded by poor circulation to heal up that injury can put people's feet at huge risk. And it is really difficult for people to perceive that they can't feel their feet. It's really, you know, pain is such a huge motivator for us to keep ourselves safe. And if you've lost that pain sensation, that hot sensation, that sensation that your feet are not comfortable, then your risk of injury is huge. When I'm delivering the patient education, I'll often describe it to people, and because you're up and you're moving around and face to face usually, I'll often say, so if I walk across this floor and I stand on a pin and I haven't got diabetes, I'm going to pull my foot away really quickly, and I'm going to lift my foot up, and I'm going to rub my foot, and I might limp around on that foot because it now hurts, it's now sore. I've had a pin in my foot, and I'm going to limp around. And I often joke and say, and I'm going to take a day off work and sit in front of the telly with my foot up because it's sore, and I'm going to look after, and I'm going to make the most of you know, resting my poor foot because it hurts now. Whereas if you haven't got that pain sensation, you walk across the floor and you come across that pin, you put your whole weight down onto that pin. You've not pulled your foot away quickly because you felt it. You've not felt it, so you've put your whole weight onto that pin, and you then carry on walking around and going about your normal work. And it might not be till the end of the day that you take your shoes and socks off that you notice that you've got an injury, that there's a pin stuck in your shoe, or you might never notice that because you just can't feel it. And subsequently, you carry on walking around on that injury because there's no pain sensation to tell you that you need to rest that your foot's in trouble. Sometimes the podiatrist will call it a foot attack because, you know, the tissue will get very damaged very quickly, in much the same way as the tissue in the heart will get damaged when you have a heart attack. So the diabetes and high risk foot will see people at that you know, very high risk, loss of feeling, loss of circulation. Again, some transition going on around people who've got who've never had an injury on their foot. They're just detected as having poor circulation and poor feeling, and whether they need to be managed in a different way to a yearly check with the podiatry team, whether someone else can still do that yearly check just because of the numbers. But the most of their work is on people that have got active foot ulcers or have been healed from foot ulcers and are now having regular reviews. They also provide specialist footwear and so on to protect a foot ongoing. So and unfortunately a very busy service. You know, when you kind of think that, you know, the wounds, we should be able to prevent these wounds, shouldn't we? But the people's feet are just so vulnerable when they've got no feeling and poor circulation. So that's the high risk foot service. The community team, we'll talk about us a little bit later, but of course also your district nursing services will see people with diabetes, and probably people with diabetes will touch most services within HFT, but district nursing I mentioned because they tend to look after the most vulnerable people who are housebound, people who can no longer look after their diabetes themselves, particularly those that can't give their insulin themselves anymore. Next slide. Okay, so if we think about the community diabetes team, the team comprises nurses, specialist nurses, dietitians, diabetes specialist dietitians. We've got a fabulous team of specialist support workers. Some podiatrists in our team. We notably have a podiatry educator based within our team. We have a small admin team, And we have a little team of bank educators as well that work with us. And we have some consultant leadership time from Northampton General and from Kettering General as well, to support with some of those, if you like, those crossovers where that people may not want to see secondary care, or we might want to avoid people seeing secondary care, and we can have that sort of supervision and that interaction with diabetologists, the hospital consultants. And new technologies and new treatments will often come down from that hospital setting into our service as a specialist setting as well. So how we'd get people into our service, how we would receive our referrals, really. So the top end is your super urgent, if you like, your red referrals. These are the ones where we're looking to avoid people going to hospital, really. So people with acute hyperglycemia, so that's acute high blood glucose, so blood glucose that's now making them feel poorly. And severe or recurrent hypoglycemia, so low blood glucose, so where they've had to have third-party intervention, someone's had to help them out, or they're having lots of hypos persistently over a short space of time. These would be the people that we would want to see within 48 hours. Now, we wouldn't necessarily see them face to face. We may see them remotely via a telephone conversation, or it might be that we're assisting another care provider to manage that situation. So it might be that we're advising district nursing. It might be that we're advising practice nurses. It might be that we're advising a care home to manage that situation. Invariably requires some manipulation of their existing treatment. So those would be our what we class our red referrals. Now, somewhere in between red and amber, we have unplanned care. We don't recognise that, really, but we get an awful lot of inquiries every day where it's not urgent. You couldn't say that actually this is going to avoid a hospital admission. But actually, this is about people living their lives with diabetes and needing the answer to a question. I'm going on holiday. I've heard about this new treatment, or I'm going to have an operation and I need to sort this out, or this has dropped off my prescription and I don't understand why. And people that maybe self-refer because they're having a few hypos, or they're changing their job and need advice about manipulating their insulin differently because they're working shift work, or all sorts of unplanned inquiries come into our service that you couldn't say, you couldn't leave them for 6 or 8 weeks for a routine appointment. They need that answer now so they can carry on with their lives with diabetes. And it's really hard to capture that, but I think our staff would probably say something like 50% of our work falls into that unplanned care, the stuff we didn't know we were going to do when we came into work this morning. And of course, we're a very accessible service, aren't we? So often once people have accessed us once, they have our contact details and they can get in touch with us. We don't have a receptionist telling us that there's no appointments left for today. They just get passed on to the relevant nurse or dietitian or support worker to deal with. So somewhere in between that red and amber, there are this group of people that what we call unplanned care, things that we can't ignore, we need to address, but it isn't urgent and it's not going to avoid a hospital admission. And then we have more sort of routine, understandable reasons for people accessing. So we call these our amber referrals, and a lot of these will be seen in joint clinics with practice nurses or district nurses. Again, our work in collaboration with other care providers. So people who are not suitable for our group education, I'll come on to that shortly, but group education is brilliant, but not everyone's going to be able to engage with that style of education. People who are going for an operation, and there is criteria for at the HbA1c, the average blood glucose reading needs to be below a certain level to be assured of a safe procedure or a safe operation. So we will see people just to optimise their treatment to get them through their operation. Chronic poor control. So the GP or the practice nurse have ideally optimised their treatment. So GP practice nurse has done everything they can, but still this person is not achieving a reasonable level of average control to keep them well long term. And then you're less able and you're vulnerable adults. This is where our support workers come into their own. They're absolutely brilliant. So they'll be seeing people at home or in their care home or in their respite care or in their day centre. But people who would find it really difficult to engage with clinic services. There's probably a huge group of people here that we keep away from district nursing services. We can do just enough to keep them independent without them actually needing somebody else to actually administer their insulin, for example. Or we're working with carers or other professionals to keep them independent and keep them, not needing to call in district nursing services. And sometimes that is really, really important, because if you've got type 1 diabetes, generally that's managed by multiple injections. And of course, district nurses are not in a position to go out repeatedly and administer insulin to people. So generally, district nurses will administer insulin once a day, and in some cases twice a day, but they certainly can't go back 4 or 5 times a day to administer insulin. So this is maybe where we would be working with carers, relatives, to keep someone independently at home and managing their diabetes. People who have been through our group education might then need some self-management support to achieve their goals and their actions that they've identified through the group education. And people with type 1 diabetes, complex management, and our DAPHNE graduates, so people who have attended our structured education, our DAPHNE course for type 1 diabetes. And then we're talking the DAPHNE language. So you've got the science of DAPHNE, you've got the tactics, you've got the strategies. Not everyone's going to know that. So they'll need to access the educators within the community team. And we are now only in the community team. It's not delivered in the hospitals at all anymore. To have the conversations about carbohydrate ratios and quick acting doses, and doing fasting checks for their basal insulin and so on and so forth. So it's or managing sick day rules according to the DAPHNE principles. So it's my computer is running low on battery. That is not good, is it? This is relocating, isn't it, at its best? So yeah, complex management there. So next slide. Can I just pause while I get a power cable? Won't be a second.
Please do, Lindsay. Yes.
Thank you. Sorry about this.
Whilst Lindsay's just getting some power, probably worth just saying that we will shortly be taking questions and so forth. So if you have had any thoughts or questions as you've been going along, please do put any of them in the chat, as we can pick questions out from the chat as well. It's worth saying that we can share the slides that Lindsay's using after the session. There's a wealth of insights here that Lindsay's providing in terms of the local service offer and also the condition itself. So we will make this available to people after the session as well. And as I mentioned right at the beginning, we are recording the session. So if you did want to go back and revisit any of the points that Lindsay has raised, you will be able to do so just as soon as we've managed to get the recording up on the website. Thanks, Judith. See some questions coming through here, which we can pose to Lindsay when she's back.
Sorry about that.
Ah.
Okay. So if you move on to continue with our AMBER reasons for referral, our dietitians within our team will work with people who've had unintentional weight loss, things like celiac disease, and as I said, gastroparesis, where absorption of nutrients can be affected and subsequently affect blood glucose levels. And of course, things like kidney disease, people will need support with a special diet. They will support people with their weight management. So ideally, they would have some initial support with through the group education, and then, as I said earlier, people would identify goals and actions, and then the dietitians would support them with those goals and actions going forwards if they needed. And preconception advice. So preconception sort of crosses between secondary and our service, really. So we might initially pick that up, say working with in general practice, and give initial advice, and then move them on to a preconception type service within hospital services. We have a small wellbeing team sort of linked with the Diabetes MDT called Talking Health Northants. Now, it used to be the Diabetes Wellbeing Service, but now it's Talking Health Northants, in recognition that significant numbers of people with diabetes will at some time during their life develop what we'd call diabetes distress, where that demand of managing a long-term condition adversely affects their mood and their mental health. So, and that can create problems with actually looking after yourself, and it just becomes all a bit too overwhelming, really. They also see people with, say, needle phobias and things like that. So Talking Health Northants specifically looking after people that are being adversely affected by having diabetes. They've also expanded now to support people with other long-term conditions as well. So we're really lucky to have that service within Northamptonshire. It's certainly not everywhere. Next slide, please. And our green referrals are the huge remit of patient education, the groups, if you like. So where people are suitable to attend a group, and the groups are hugely valuable. People will often say the patient story I talked about earlier this afternoon. In 57 years of having type 1 diabetes, the chap said that he'd never actually sat in a room with other people with type 1 diabetes and talked about diabetes. The groups are just so valuable. So it's just precious time, and gives people time to sort of talk to each other, share experiences, share ideas, share learning, and so on. They are really very valuable. So Desmond, our diabetes education for self-management of ongoing and newly diagnosed type 2 diabetes, is available for people who are newly diagnosed within that first 9 months of diagnosis. We deliver it face-to-face, we deliver it remotely via MS Teams like this, and we also have a digital option called My Desmond as well, which we can put people in touch with, and then they can work through an education programme on their mobile phone or their computer. Daphne, our dose adjustment for normal eating, is structured education for people with type 1 diabetes. 6 to 12 months after diagnosis. Initially with diagnosis, blood glucose can be very stable because people are still making insulin. So we call that the honeymoon period, and we really need people to sort of be a bit beyond that honeymoon period before they attend Daphne, to make it meaningful. And people do repeat it. If you imagine living 57 years with type 1 diabetes, people do come back 2 or 3 times for more of a refresher and to remind themselves. All of us with lifestyle change would find it really difficult, don't we, to keep it going long term. We all have good intentions of taking up regular exercise or managing our weight or adopting some healthier eating habits and so on. It's very difficult to keep that going lifelong. So people do often come back and repeat the Daphne course. We also do a Daphne refresher session twice a year. In February, we did have the first refresher session for this year, and we had 52 people came to that. So it is incredibly popular. And we have sort of bases that do sort of refreshers on various tactics and strategies. We have invited speakers and invited guests as well. So that's really popular. We tend to run it north. We did it at Kettering in February, and we'll do it somewhere in the south of the county, probably September, October time. We've also got our dietitians have designed a course for carbohydrate counting, mainly for type 1, but some people with type 2 do benefit from carbohydrate counting. So that's the ability of being very precise about the amount of carbohydrate food that you're consuming, and it gives you the opportunity to much more accurately link insulin injections to the amount of carbohydrate you're eating. Historically now, and this is something this chap on his story didn't mention, but we used to limit the carbohydrate. People would be given a diet for their diabetes that had measured portions of carbohydrate in it, and then fixed amounts of insulin. So they'd have a fixed insulin regime and a fixed amount of carbohydrate they were allowed to eat during the day. And I say allowed to eat or had to eat, so it went both ways. To try and balance that insulin and carbohydrate. We've turned that completely on its head now, and now we do the carbohydrate counting, but much more about being flexible, so people can manipulate what they're eating and manipulate the insulin to suit what they're eating. For ongoing type 2 diabetes, for people who are struggling to manage, struggling maybe with their weight, people who are maybe moving on to insulin treatment in type 2 diabetes, we have some other sessions people can attend. So diabetes and carbohydrate awareness. So this is about understanding about carbohydrate and portion size rather than counting or measuring carbohydrate precisely. Living well and eating well. There was a lovely comment from a chap who we were phoning about. He'd come to the first session, the diabetes and carbohydrate awareness, but hadn't come to the second one, living well and eating well. And when our administrator phoned him up and said, well, you missed the session, would you like us to book you into another session? He said, I'm living very well, thank you, and I'm eating very well. I don't think I need it. That's just a lovely comment. So yeah, living well, eating well. It focuses much more on good health, so it will look more on blood pressure management, cholesterol management, exercise, things like all those sorts of things that keep a body healthy, all those sorts of things to help reduce that long-term cardiovascular risk. People are progressing onto insulin treatment. We can do sessions on insulin management. And Me and My Diabetes is a course of sessions that we've designed with the learning disabilities team, specifically for people with a learning disability. Now, we pulled that pre-COVID because it was really felt by the people on the waiting list that they couldn't engage remotely, and it really needed to be face-to-face. So we're trying to rekindle it now, and we've got some connections with the learning disabilities team, and we're hoping to do some work together just to relaunch that and try and get that up and running again. We designed it years and years ago with the learning disabilities team, and actually the Desmond Collaborative in Leicester wanted to design a session, and they came and watched our session and designed their own session out of the information they saw. They worked on with us, so it was quite good. So we really need to get that one up and running again. But we need the engagement of people in the learning disabilities team to make it work really well. Next slide, please. So thinking about staff training that we provide, we've got the CHIP project, or the Care Home Insulin project, going on at the moment. This is a project for the district nurses really to delegate insulin administration to their population of housebound individuals who are living in care homes. So we provide the training to the care staff so that they can understand about diabetes. I think there's a good is really quite a weighty piece of learning for them to understand about diabetes, and then to be trained and signed off as competent to administer insulin to named individuals. So it's very specific to named individuals. The care home gets someone else in on insulin, they can't automatically administer their insulin. They have to have some training on that individual's diabetes needs. So it's a delegation of insulin. The patient remains on the district nursing caseload in case there are problems or issues, or the care home's got staffing issues and the district nurse needs to take over, or the blood glucose becomes unstable and the district nurse will need to take over again. And the district nurse needs to do a full weekly review of that patient with the care staff. So we've provided, I think it's somewhere between 10 and 12 care homes we've trained, and something like 120, 130 care staff that we've trained. Potential to save huge numbers of insulin administration visits, but we're finding at the moment that it's very difficult for the district nurses to even maintain the 4 weekly caseload reviews. And very difficult for the care homes. They've got such transient staff, so many staff coming and going all the time, that it's been very difficult to actually keep people long term administering the insulin in the care home. It's a much safer way of doing it for people with diabetes. For example, if someone's needs to have their insulin before their breakfast, that poor person's got to then sit in their room and wait for the district nurse to come before they can go down to breakfast and join everybody else. And insulin is time important. So, getting insulin at the right time, is really important in diabetes. So being able to support care homes to administer the insulin to their people who require it in the care homes, it's kind of a no-brainer in my head, but actually making it happen is proving much more difficult. We've got some role-specific training for people in NHFT, clinical staff who see people with diabetes. There is role-specific training. It's currently e-learning, but with the option of some face-to-face competency training too. As I said earlier, new treatments and technologies will often come to hospital care, but then will tend to either include us or devolve down to the community service. So we're looking at that flash or continuous blood glucose monitoring. So the flash, if people are aware of it, is where you can have an app on your mobile phone and just swipe a sensor on your arm, and that will give you your blood glucose reading. And as long as you do that 4 times a day, you'll get a profile, 24-hour profile of what your blood glucose is running at, the highs and the lows, and what happens after meals and what happens when you exercise and all sorts of things. But there are sensors, there are CGM now as well, that you don't have to swipe anymore. So they do just continuous monitor, and you can look at that progress on an app. It is a challenge. This is where we're moving into technology, isn't it? And a lot of us trained as nurses and care staff, we're not technicians. We didn't really, a lot of people still struggle to use the computers and mobile phones and all sorts of things. And being able to use this technology does mean you have to juggle between lots of different apps and lots of different platforms, because each manufacturer will have a different platform that you can read the information on or download the information on. A lot of people with diabetes want the technology, but struggle with managing it on apps and on phones and on computers and things. And this is where I think we may be moving into a time where you need technicians in diabetes services to manage that. Our nurses are reporting they're spending so much time having to. This is my meaning, isn't it? Where you get your mobile phone and it needs an update, doesn't it? And you've got to go up to release 13 or whatever it is on your phone, and the app, your continuous monitor, won't now talk to your phone because you've got you've not got the up-to-date app. And Daphne, we delivered recently, a chap had got one of the other CGMs he wanted to try, and he took it away and said, oh, it's not compatible with my phone. And my colleague, who's much more tech savvy than me, said, oh, you'll get an update on your phone in a few weeks time. Hold on to it and try it again when you've had a phone update. And it's like, where are we in the world where nurses are having to advise patients on updating and accepting updates on their phones so that they can use health technology? So I think we're moving into a time where we maybe need some technicians to support patients and support staff with managing the technology and coping with the technology. Something we have done is work with the district nurses on people that they've got on their caseload with memory problems or dementia, and these are often people that they only go into once a day, possibly twice a day. That's the only time they get their blood glucose checked. So we're completely oblivious as to what happens at night, early in the morning, in the afternoon, all these kinds of things. So we've been doing a little project of trying that continuous blood glucose monitoring on those patients, and out of 7 that we tried, I think 2 or 3 of them came off insulin. One of them moved from twice a day to once a day insulin, and the others had significant reductions in insulin. So although the district nurse was going in and reporting high blood glucose on the patients, actually they'd got significant times during the day where they were very low, and that was much more dangerous for them than the highs that they were getting with the district nurse after breakfast, for example. So we're looking at sort of expanding that a little bit, really, because I think it's definitely something that can be really helpful in district nursing, and for patient safety as well, where they're only going in maybe once a day and the person is unable to report that they're going too low or they're having symptoms of their diabetes and all those kinds of things. So we've done, like, so we've tried it on 7 people, and we really want to extend that project. Injectable therapies, insulin and GLP-1, we certainly do training to use the technologies and the new treatments. We will support the administration of insulin, but ideally, and in some cases, GP practices should be able to move their people with type 2 diabetes onto injectable therapies as they need them as part of their journey with type 2 diabetes. The longer people have type 2 diabetes, the more likely they're going to need insulin treatment. So that is kind of part and parcel of that journey. People might have heard, it's been in the news hugely in the last week or two, hasn't it? The GLP-1 injection for weight management. This is a glucagon-like peptide, GLP-1. It's the opposite, if you like, it's a bit like the opposite hormone to insulin, glucagon, made in the pancreas. And what's been discovered in more recent years is that all of us, when we eat food, we make these incretin hormones. We make these hormones in our gut that tell our brain we're eating, so they reduce our hunger feelings, tell our liver that we're eating, so stop the liver for pushing out more glucose into the system, slow the digestion a little bit, so keep you feeling fuller and give the body a chance to digest and absorb any glucose out of the food that you're eating. And what the GLP-1 is a copy, if you like, a mimetic to that hormone activity. So very good at helping people with type 2 diabetes, and we've used it in type 2 for a long time. But the recent press is looking at using it in people who have weight problems and helping them lose weight, because as well as helping manage blood glucose levels, it has been found that people can lose significant amounts of weight as well. Whereas it being used in weight management, it's only a 2-year prescription, whereas in diabetes there isn't a limit to how long someone, if it's benefiting them, then they will stay on that treatment. I've talked about insulin pumps already. Diabetes foot awareness and screening. Our podiatry education, I mentioned our podiatry educator a little while ago, will provide face-to-face training. We'll do it remotely like this as well, but we'll also go out and provide face-to-face training for general practice, district nursing, inpatient areas, community staff, to help people understand that risk to the diabetic foot and the importance of referring people into those specialist services really quickly. So nice guidance is that people with a foot wound, if you like, needs to be referred to the high-risk foot service. It's a same-day referral, and the foot service need to see them within 48 hours, working hours. So it's a very quick move, referral response. And where the team pick up patients that have been harmed because they weren't referred into the service quickly enough, they will then go and do some education to support them to understand what the process should be, and why the process is there, why it is so important. Next slide, please. We're nearly there. Yes. Okay. Was there another one, or is that? Are you hurrying me up?
That is your last slide, I think.
That is my last slide. Oh, yeah. Thank you very much. I could talk on forever. Sorry.
Thanks very much, Lindsay. I was just going to say, whilst you were getting a power cable, we did have a few questions that popped up in the chat to start us. Start the ball rolling. A couple of people were interested, particularly linked to the conversation we were having about the higher prevalence in some parts of our community, what work we're doing to support those ethnic diverse communities to be more active. Is there some work that we're doing in that area or planning in that area at the moment?
Pre-COVID, we were trying to develop an adapted Desmond for use in ethnic minority populations. It's a structured program, and subsequently there's a curriculum, and they're if you like it, because it's an evidence-based program, you have to follow certain rules, if you like, to adapt it and fit it into various populations. So we had done a lot of groundwork on that, but it was proving quite challenging to get enough engagement from the population to lead it from their perspective, if you like. So to be able to launch it properly as a regularly run program, it was proving quite difficult. And then COVID hit, and we've not got back to that yet in being able to do that. We do lots of awareness sessions and groups for various ethnic groups. We can provide Ramadan and fasting sessions for people with diabetes and for other healthcare professionals as well. So specifically for ethnically diverse populations, we don't exclude them from anything that we're currently doing, and lots of people will access that. But doing anything specific, we haven't succeeded in anything on a regular basis, other than being invited in and providing sessions or suggesting sessions and going into various populations across Northamptonshire. So yeah, we can visit, we can go in, but anything specific within those population areas, we haven't been successful in. I have been invited into, with the changes with the ICB at the moment, there are various like support groups, what they're called asset groups, being set up. There are warm space groups as well being set up, and we have been invited into some of those sessions as well.
Thanks, Lindsay. So I think Matthew asked one of the questions in this area. So I don't know, Matthew, whether you want to come in off the back of what Lindsay's said there.
Yeah, it was, in ways, I was surprised to hear nothing proactively being done above the kind of everyone's welcome. It's the biggest conversation starter we hear within the Southeast Asian community is diabetes. There's a big concern both within those who have been diagnosed and those that just live unhealthy lifestyles around that. So we funded a couple of organisations who got trained diabetes coaches to run sessions. So they're getting people along, but then trying to round it in for referrals in where they train people, but we don't seem to get any traction on that side. So seeing where we can link in with that. But then also probably further conversations. How do we get the conversations back started? We've set up with Northamptonshire Black communities together a sports and physical activity forum, and as part of the visioning and plan for the next 5 years, a lot of it comes down to these communities want medically proven activities. That's where they see the real benefit. So looking at what can be done to kickstart that program you were mentioning there, but really not just us putting it on, but really working with those communities from the start to co-design it, get them delivering the sessions, use their real assets as part of this, not just go to them with the product and say, now we want to work with you.
Well, that's what the Desmond was. It was about working with the populations to adapt it. So go with the if you like, the blueprint, and engage those populations so that we could design because every population is going to be different, aren't they? None of them are going to be the same. So, you know, if you kind of think of all your Eastern European populations as well and all sorts of people, you could end up with, you know, lots and lots of different programs. So it's very much going with the blueprint and then working with populations to make the adaptations that they need. And in that way, Matthew, you get the evidence base as well, don't you? So the Desmond and the Daphne are both evidence-based programs. So yeah, so if you've got any ideas, I'm more than happy to listen to them. But like I said, it proved so difficult. It really did. And I can absolutely remember just before COVID hit, we just set up this group and we'd got 4 members of the Asian population key members of the Asian population in Wellingborough that one of our administrators has managed to secure for us. And we were about to go in and meet with them, and COVID hit and we had to cancel it. And then as we got live with the MS Teams and everything, we tried to get back to them to join an MS Teams, and it just wasn't happening. It just couldn't get it together again.
I should have introduced. I work for Northamptonshire Sport as our inequalities lead, and it'd be something really keen to pick back up. So if you need any support, either myself or my colleague can. Because we're doing a lot of work in Wellingborough with the Southeast Asian, with a lot of other populations, Bangladeshis. So we're keen to support that. Yeah,
I mean we have done quite a bit, but I'd really like, and it really should be something that we can do. It should be a regular thing. And I do wonder with the changes in the ICB, we are finding lots of areas are setting up these asset groups, these support groups. They're setting them up. And then they're coming to our team and saying, can you now support this group? And that's actually quite tricky to do on a small clinical team where you've got, nearly a doubling in population since it was originally formed. So it is really hard to, but I think that's the way it will go, Matthew. I think it needs to come from the population.
Oh, definitely.
We need to engage with it because like you say, us doing it unto them just, it's been great. We've done some great things, but we've not been able to do anything to keep it going.
No, that's where ourselves and other organisations, we're writing the physical activity framework for the county, but the Black Moving Together Forum are writing their vision and their reply to it, and very much diabetes is in part of that. The using the assets from within and the medical data. That's what gets people through the door for these communities. But thanks. I think Chris had a similar point on that.
Thanks, Matthew. Yeah,
thank you, Matthew.
Sounds like there's a real partnership opportunity there, doesn't there, in terms of the connections you've already got as an organisation with us, and as you say, Lindsay, with the new, I think they're called local area partnerships and community wellbeing forums that are emerging in different areas. It looks like a real opportunity, as you say. Now we're coming out of the other side of at least the worst phase of the COVID pandemic, hopefully, and doing more face-to-face work. That does sound like something we could pursue. So thanks very much. Let's bring Chris in next.
Yeah, can everyone hear me okay?
Yeah.
Yep. For those who don't know me, I'm Chris Dayson. I'm the lead governor for NHFT. I'm also a public governor for Kettering and Corby. And I just wanted to say, Lindsay, thank you very much. I think there's so much to admire about the service that you provide and some of the technical details and knowledge that you went through. Sorry, lost my screen there. It's interesting, I think, the conversation between Matthew and Lindsay, I think it's at the very hub of where we are at the moment, in that as a governor, I have a foot in the NHS, which is heavily controlled, managed, regulated, but also a foot in the community where things are organic, they evolve, and they're based on relationships. So Matthew and the relationships he has with the, the Northamptonshire Black communities, with the BAME network, as I mentioned at the top of the meeting, with my knowledge of dealing with the Southeast Asian community. And I think the point I want to make is that having done a lot of this patient-facing or public-facing community engagement events, we assume people know where to go. And yet my experience is that because of the people's colour of their skin, because of disability, because of social circumstance and digital exclusion, they don't know where to go. And I think what is wonderful is this is the whole point, isn't it, Richard, of these members events, is to provide those links. And I think there's a great example of how we can come alongside community groups. I think to reinforce your case, Lindsay, for extra staff, I think the 2021 census showed that the population in North Hants, from memory, went up by, I'll say 13-14% in the last 10 years. So we currently have, 785,000 people in Northamptonshire. I think you said 50% are known to the service, something like that, which by my maths is around 6%. Now, I'm sure there is an unmet need here. And what I was really thrilled with, and I'm coming in to land on this question or observation, is that you provide this peace of mind service. As you said, you come into work, there's probably 50% you don't know what's going to happen that day, and you provide reassurance. You provide helping people to stay well and live well. And I just think that this is a great example of a service around population health, maintaining people staying well, living well, but we can't do it on our own. As you said, I made this note myself, we have a tendency in the NHS in certain services to do unto you. And I think what is great, and a takeaway for me, is this conversation between Matthew and yourselves about how we could perhaps provide a framework to go further, farther and deeper, and support you, Lindsay, with a case for more resources. There, I'll shut up now. But this was all running through my head, and I hope I articulated that in a way that came over. Thank you.
I think it's really interesting, isn't it? Because I do think there is so much more that could be done, isn't there? And there is so much more engagement, across so many different populations that that could happen. But I often think as well that you kind of also get hammered by that, the national guidance and the nice guidance, and you have to do this and you have to do this and it has to be this way. And I think sometimes, we almost disempower ourselves. We make it too difficult to do anything because we've got to keep it safe and it's got to be this quality. And sometimes I think it almost makes it feel too impossible to do sometimes, doesn't it? You kind of, it all becomes in the too difficult box.
It makes it, and this is where we have to go as an NHS. I'm hoping, as Richard knows, through the ICS, through local area partnerships. My career and background's in the NHS, where, as you say, things are heavily managed, they're regulated, they're controlled, more risk averse. And yet with population health, we have to move into a space where we're prepared to take more risk, that we're prepared to try things out based on relationships. And that is in my view, a paradigm shift from where we currently operate and moving it into a different space. I would say this because I'm a governor, but I think governors can help with that, bridging that gap and building those relationships. Thank you for nodding, Richard, that's kind of you. But I do think, one big take-home message for me is that brilliant conversation about how we can move into population health, preventing people getting ill and staying better rather than falling over and having to go to A&E because that's the only place where the lights are on. Brilliant, though, Lindsay. A lot to admire from your talk.
Thank you. I mean, we are undergoing a transformation of the diabetes pathway. That's not just our service; that's the whole pathway. So, it is a real opportunity to make some changes.
Mm-hmm. Thanks very much. Yes, and I think at this time of the year, we're all across the NHS and to a lesser extent the local authorities looking at planning for the next financial year. So we are thinking about all those things such as population changes, new national priorities where they exist, and other things to make sure that we are doing the best that we can with the resources available. And I think you're right, Chris and Matthew, that actually there is an opportunity to make sure we're using Lindsay and her team to the best effect by working together in partnership, not least with other organisations, but also with patients themselves and family members who, as Lindsay was describing, increasingly are want to and are able to, through technology or otherwise, take greater control themselves for their lifelong condition, which is in some ways great to hear. So I want to just make sure we pick up some of the other questions in the chat. So I didn't want to gloss over the feedback from Simon, who feels that the Daphne group is hugely beneficial for those with type 1, particularly the opportunity to interact with peers. So a thumbs up from Simon there in terms of the Daphne course, Lindsay. But a question here from Robbie. He was wondering whether you could say some more about semaglutide tablets to assist in weight loss and lowering HbA1c.
So the tablets it's a tablet version of the GLP-1 injections I was talking about. It hasn't got the cardiovascular benefits, or it hasn't got as much evidence for the cardiovascular benefits as the GLP-1s have. There are several different types of that GLP-1, and they can be matched to individual need. So as far as the criteria go, it's got really complicated. Many years ago, when you were managing people with type 2 diabetes, you'd start off with your lifestyle and your diet management and everything. Then you'd have metformin treatment. Then you'd have a sulfonylurea treatment, was usually glyphosate, and then people would go on to insulin. And it was very simple pathway. Whereas now there's a huge, it's like a giant Sudoku of different treatments that are available for different people. It's matching the treatment to, it's much more about the individual and where that individual is with their health, and which combination of treatment would suit them best. So there is the GLP-1 tablet as well. But I think generally the preference is for the injected therapy. There are some of them that are once daily injections, some of them that are a weekly injection as well. So they are, they are great if people, you still need to engage with that diet and lifestyle change as well, but they can be really, really helpful. Generally, people with type 2 diabetes really find that very difficult because hunger, again, is a big motivator, and people with type 2 diabetes do feel hungry, and we think it's to do with that gut hormone, that lack of gut hormone, and switching those hunger sensors off in the brain. So it's really difficult to lose weight and manage intake, and these injectable therapies help in that way. And then if you can lose that significant amount of weight, then there is that opportunity to reduce other medications. For example, often if we start a GLP-1 treatment with insulin, we'll half the insulin dose because we anticipate a lot less insulin will be needed when this person starts a GLP-1 injection. So it is a bit of a Sudoku about which treatment would work best. There's also another newer treatment, the SGLT2s, that you might have heard about that tablet. It works by stopping reabsorption of the glucose in the kidneys. So you excrete more glucose from your body. You don't keep it in your body, you get rid of it a little bit more. So that's another option for treatment as well. And that has some links with weight management and cardiovascular health as well. So we're almost moving away from treatments that are predominantly to control blood glucose and into treatments that will help with those long-term risk factors that come with diabetes, that cardiovascular health, that kidney health, and so on. So some of these treatments, they're an option in reducing long-term risk to health, not just keeping blood glucose down. But yeah, have the conversation with your GP. Like I said, you should be having that annual review, and that would be the point at which you would have that conversation about what treatment options that you've got. And I think that you there's probably information prescriptions and things on the NHS website that would go through that, and you could certainly look at the NICE guidance and have a look at that. You don't print it out, this form, because it's like a giant Sudoku. You open it on your computer and then you expand the sections that you want to read. There's so much information on it, but it is a guideline for working through treatment options in type 2 diabetes.
Thanks very much, Lindsay. So, as we approach at the end of the session, just an invite to anybody that's listening that hasn't yet had the opportunity to ask their question to do so now. And to you, Lindsay, is there a sort of a key message that you want to leave people with as we come to a close? Might be about how to find out more information, or there may be a key piece of advice, a top tip, for instance, that you might want to give people. I'll leave it open to you, but I don't think we've seen any further questions coming up in the chat. So I'll hand back to you to finish off for this afternoon. Thank you.
Yeah, no, I would certainly, if you know people with diabetes, I would absolutely encourage the group education if it's on offer. Encourage that group education, because it invariably the feedback is excellent and people get an awful lot out of it. But people, because we call it education, if anyone's got any ideas of what else we could call it, I think education maybe puts people off. Maybe we should call it something different. And like I said, some of these, engaging with some of these community groups, these asset groups, we are beginning to think actually, rather than setting up a group and saying, can you come and do a half-hour talk for us? So we're wondering whether actually that's the way to take the education into those asset groups and do it and deliver it in that way. Because invariably the questions are the questions that would be answered through the structured education. Yeah, I'd certainly, any suggestions or ideas of looking at things differently, certainly given that we are transforming services as we speak, all those discussions are happening. So any thoughts about how we could do things differently, most welcome. And if anyone wants to join our diabetes network in Northamptonshire and engage with those transformation sessions, more than welcome.
I will. I'm happy to.
Please. Do you want to email me and then I can pass it on? They're organised by the ICB, so I just get you on the mailing list.
All right.
So if anybody is interested in doing that, if they want to use the email address they use to register, I think that's right, Tracy, people will have that Foundation Trust email address, and we can then facilitate a dialogue with Lindsay to get you on that list. So I suggest respond to the email that comes in with the slides. It's probably easiest, isn't it? I would imagine. Yeah.
I've got some little posters I can send you as well, Tracy, if you want to send that out with the slides.
Perfect. That sounds really helpful. So yeah, so I think we've just covered everything in the chat, and the suggestion, Lindsay, that we might want to think about framing it as an awareness rather than an education session. So something to think about there. So just to say thank you very much both to you, Lindsay, and to everybody that's been involved this afternoon. I've certainly found it hugely informative and useful. As ever, it's great to see such a range of people engaging with these sessions. I mentioned right at the beginning, this is unfortunately the last of the 22-23 sessions, but we're soon in the new financial year in April, when a fresh batch of sessions will be coming up. So do stay tuned to see what we've got in store with different topics related to the services that we provide in NHFT. So look out for some more information on those. As always, as Lindsay sort of alluded to, we're really interested in hearing your feedback on these sessions. Are they useful to you? Is there anything that you feel we could do to make them even better? So again, when you do get a copy of the slides, do let us know, as we want to keep improving these sessions as we go forward into the future. And so with that, and it just being after 5:30, thank you very much, everybody, and have a very good evening. Thank you.
Thank you.
Good. Thank you, Tracy. Thanks, Lindsay. All the best.
Thank you very much. Thank you.
Bye.